Good afternoon, everyone. Only 3 more to go on day 1, so we're almost there. So today we'll be presenting to you a brief overview of my practicum placement, followed by highlights from my practicum project, which included a scoping review and case study, both investigating the role of the nurse practitioner in specific contexts. From January to March of this year, I completed my practicum placement in the Research and Evaluation Department at the Dr. Peter Centre in Vancouver, BC. As part of the Dr. Peter AIDS Foundation, a nonprofit organization, the DPC provides support to some of British Columbia's most vulnerable citizens who face poverty, homelessness, mental health, and addiction issues, in addition to HIV/AIDS. The center operates 3 core programs: a day health program, a 24-hour specialized nursing care residence, and an enhanced supported housing program. The primary focus of my practicum placement was on the creation of a case study document with the potential for academic publication that articulates the role of the nurse practitioner at the DPC. So in the interest of time, the focus of this presentation will therefore be on the case study. The DPC introduced the nurse practitioner, or NP, role to its programs in 2008, creating a unique care context in which the roles of the NP have rarely been documented, particularly in relation to harm reduction and strategies such as supervised injection services. The role was introduced to the DPC team in order to enhance care and attempt to prevent some of their most complex clients from falling through the cracks. It was important to the DPC to highlight this unique role and to build from the findings of the case study to optimize the role of the NP in their model of care. To give context to this area of interest, I first completed a scoping review of literature to investigate the role of the NP in supervised injection services and other forms of harm reduction. I started this review in Kathy's PHSP 506 and completed it in the early stages of my practicum. Building from the findings of the scoping review, I developed the case study report to provide an articulation of the NP role in the integrated HIV/AIDS healthcare setting at the DPC, and as well considered the implications of the role being situated in and supporting an environment that addresses the social determinants of health and the barriers faced by the vulnerable populations that access the services at the DPC. Information gathering for the core of the case study was conducted by utilizing the foundation of knowledge gained from the scoping review of literature, as well as by consulting with 3 key stakeholders at the DPC, as you can see listed on the slide, to gain their insights regarding the role of the NP in this unique care context. Consultations were informal in nature and were repeated several times throughout the creation of the case study. Information gathered from these consultations was then synthesized to present an articulation of the role of the NP at the DPC in the form of a case study document. The core of the case study focused on describing the role of the NP at the DPC in relation to the 3 core programs, as well as thematically, drawing from the broad role elements of the NP that were identified in the scoping review. The advanced practice scope of the NP was recognized by the DPC team as an opportunity to consolidate and enhance nursing practice in their existing programs, augmenting care by facilitating collaboration with participants' primary care providers and assisting to ensure effective and efficient utilization of resources and interventions for DPC participants. On a day-to-day basis, Martin Payne, the nurse practitioner at the DPC, provides a range of care and services in all 3 of the DPC's core programs. By adapting the broad role elements of the NP that I identified in the scoping review to the unique context of the DPC, the case study discussed 6 key areas of Payne's role. And these included facilitation of access to services, which comes in particular from the diagnostic and prescriptive authority of the NP, holistic care within a multidisciplinary team, which is based on the traditional nursing focus that considers the health of the whole person, utilizing harm reduction principles through a commitment to working with clients in a manner that minimizes the risks associated with certain behaviors without requiring that the behaviors stop, and to minimize as well the barriers to accessing care that many clients face. Client education and support utilized the expanded expertise and knowledge base of the NP to bring client education and support to a deeper level, particularly in terms of medication adherence and comorbid illness. Supporting and mentoring a multidisciplinary team by contributing an enhanced level of practice and knowledge base to an environment that manages particularly complex clients. And finally, contributing to evidence-informed practice at the DPC through the development of evidence-informed policies and practice standards. Returning briefly to my results slide, in terms of key challenges to the NP role in the context of the DPC. These included the challenge of communication in a shared care model, the challenges of establishing a clear role definition for the NP, particularly within a new care context, and finally, the lack of a broad research base from which to develop the role. Given the detailed description of the role of the NP at the DPC, I then considered the ways in which the role is situated in and supports an environment that strives to address the social determinants of health and the barriers faced by the vulnerable populations that the DPC strives to care for. In this section, I focused on social exclusion as a social determinant of health and utilized a risk environment framework to consider the implications of integrating the NP role into an enabling environment at the DPC. Mikonen and Raphael have identified social exclusion, including the denial of social goods such as healthcare and social services, as being a cause of marginalization of vulnerable groups that can ultimately impact their living conditions and personal experiences in a way that can endanger their health and well-being. The concept of the risk environment described by Rhodes offers a valuable framework for addressing social exclusion, particularly for individuals who face multiple barriers in attempting to manage the challenges of living with HIV/AIDS and drug addiction. The risk environment refers to the various contexts in which risk factors that are exogenous or external to the individual may interact, ultimately increasing the individual's risk of drug and other health harms. Rhodes divides the types of environmental influences into physical, social, economic, and policy environments, and then relates these categories to micro, meso, and macro levels of influence. The DPC alters the risk environment by fostering an enabling environment that provides a range of clinical, support, and harm reduction services for vulnerable populations of persons living with HIV/AIDS that they are attempting to reach. The enabling environment at the DPC attempts to remove or minimize the negative impacts of social situations, structures, and places on persons living with HIV/AIDS who inject drugs, thereby enabling the reduction of drug and health harms. The role of the NP at the DPC is an integral, supportive, and enhancing element of the model of care and the provision of an enabling environment which addresses the challenges linked to social exclusion as a social determinant of health. In particular, the NP is able to provide services to clients in a familiar and trusted environment, bridging gaps in care and ensuring the client receives an appropriate level of intervention in a timely manner. Overall, the NP role enhances the DPC's ability to address the denial of social goods by facilitating access to healthcare and social services, in addition to housing, health education, and food security. Employing a framework for an enabling environment that is supported by the NP at the DPC has the potential to reduce the sense of powerlessness and the degree of social exclusion that can be experienced by this vulnerable and marginalized population. At both the policy and practice levels, integration of the NP role and the creation of an enabling environment in other settings that deliver care for individuals with substance use disorders and comorbidities is a valuable strategy to bridge the theoretical boundaries between public health and primary care. Within the context of public health policy and practice, addressing the barriers to care for vulnerable populations, such as individuals with HIV/AIDS who inject drugs, is necessary to reduce inequities as well as morbidity, mortality, and overall strain on our healthcare system and the individuals within its reach. As care providers continue to face evolving roles and contexts for the prevention, treatment, and care of individuals with substance use disorders and comorbid complex illness, the NP role offers a promising contribution to the future of HIV/AIDS management. Particularly in the stable and chronic phases of illness, the NP role enables the delivery of effective, efficient, and consistently engaged care. There is a need for our healthcare system to be more effectively positioned to deliver quality healthcare services in the form of sustainable solutions in order to meet the rapidly changing needs of BC's populations. Optimizing the use of the NP role is an important part of creating sustainable solutions that will support services to fill gaps in care and increase access to care for high-need priority populations in BC, such as those facing chronic comorbidities, mental health challenges, and/or problematic substance use. Further exploration and integration of the NP role into new and evolving care contexts, such as the role of the NP at the DPC, will not only support a foundational culture of innovation and efficiency, but will contribute to a future of sustainable solutions that is critically needed for the health and wellness of our communities. I'd like to thank everyone who has contributed to my practicum experience and to this project, in particular, Dr. Kathy Worthington, Dr. Michael Hayes, Victoria Barr, as well as to the audience and the rest of my classmates for your attention today. And I would now like to welcome any questions.
Thank you, Alana. Okay, questions? Here we go. Hooray.
Do you think that the lessons learned in your project could be applied to other harm reduction places, or is it just applicable to the center that you were at?
Absolutely. So one of my limitations that I listed in my report was that this case study might be a little bit difficult to generalize. The DPC is such a unique context, and Martin Payne himself is such a unique practitioner, and that was one of the things that we highlighted. It just takes a certain style and a unique person to do the role that he does. However, this continuity of care and the gaps that the NP role is able to fill would absolutely be applicable in other harm reduction settings. So a supervised injection facility, outreach teams, et cetera, the role would be applicable, and you would just have to consider the unique elements of that environment.
Hello.
Hi.
I enjoyed the presentation. With the choice to use the word enabling, I thought that was an interesting word because it can have negative associations, and I wonder if that was intentional to kind of reclaim the word for the positive associations that could be used through it.
Yep,
I
absolutely.
just want to talk about that a little bit.
Yeah, thank you. It was intentional. It's actually something that came up in our online discussions. I think I brought up in one of our online discussions the risk environment framework and an enabling environment, and we were all sort of saying, yeah, actually we usually have a negative connotation with the word enabling. So here it's enabling people to reduce the risks of certain behaviors, and in this case, drug use.
Thank you.
Thank you.